it makes a bird beak appearance. We call them as bird beak appearance of this coracoid process. Now this tip of the coracoid process again gives an attachment to important muscle which is coming from the front side of our arm. We call them as coracobrachialis and short head of biceps brachii. So again, this point is very important. Whenever you are coming for the scapula, do remember these particular points regard to this thing. Other than this, on the upper aspects of the spine, we have a muscle supraspinatus. Lower part of the spine, we have an infraspinatus. On this shallow side, which is lying on the anterior aspects of the scapula, we have subscapularis. These are kind of like an easy piece of thing which you have to know. But whenever you are studying it, you have to remember well that we will be testing you based on this particular scapular spine. We have a reason why we are asking this particular scapular spine. Now coming from this particular scapula, about this particular joints which is participated by this thing, we have this particular cavity which is shallow one, we call them as glenoid cavity, which is making the shoulder joint. That is a point of discussion for the day, which is kind of polyaxial joint, has a wide range of mobility, which you have already learned about. So this particular glenoid cavity has a projections above and below. We call them a supraglenoid tuberosity and infraglenoid tuberosity or tubercle. These two also gives anchorage to two different muscles. One is the supraglenoid is a biceps brachii, long head, and lower one is a triceps, which is anchoring, which is long head of the triceps. Again, these are a kind of point of focus. So there is a piece of bone which has a tons of muscle attached. But in this particular region, you have to pick whichever is the prominent region of this particular muscle attachment is concerned. Prepare them well and then move to other things. Whenever you are given in a bone, say for example collarbone. So if you are given with the collarbone, you have to determine the sides, which is right side, left side of it, which is the medial side of a bone, lateral side of a bone. Similarly, anteriorly, what muscles is anchored to it. Say for example, we have the pectoralis major, we have a deltoid attached to it, we have a sternocleidomastoid muscle attached to it. So we have to emphasize on this particular muscle. We will be knowing them, then we have enough time to remember something more, we will be learning something more as well. So ensure the region which is, we call them a 60 to 70% region of a high yield area of a bone or a concept. Why the concept is more important? Because that is related to clinical anatomy. So what clinical anatomy is there, that will be helping you to focus on this particular bones, muscle, etc., etc. Now moving from this particular bone, we are moving to this particular bone which is again very familiar with us. We have the humerus, which has a long bone which has parts, upper end, shaft and lower end. Upper end have head and two projections, tuberosities, we call them as greater tubercle and lesser tubercle. In between we have a narrow cleft which is running in between, we call them as intertubercular sulcus, which is running in this particular region. Again, this particular thing have to know. Then the narrow constricted part, we call them as neck of the humerus. That is again very important for us. So this particular bone you are seeing from the front side. Now whenever you are going to study for this class, we are going to study the shoulder joint from the back side. So we will be flipping on the back side. We will be emphasizing on the back side important regions of this particular bone. So if you see this particular bone on the back side related to this particular humerus, which is point of interest to us is that this region, we have a groove running over here. We call them a spiral groove. That particular spiral groove loads some of the neurovascular structure. That is important for us. Now on the top of this spiral groove, we have a rough region. We call them as tuberosity. That particular tuberosity goes by the name with a muscle. We call them as deltoid tuberosity, because the deltoid muscle, which is an important prominent muscle on the shoulder region, anchors to this particular region. So that's why this particular tuberosity, when you are flipping this particular bone to the posterior side, these are the two landmark regions. We will be definitely asking about the spiral groove. We will be definitely asking about the content of the spiral groove. So is this deltoid region, which is related to the tuberosity, what muscle, etc., etc., anchored to it. So this is how we actually proceed to. We have a reason to target any particular landmarks. We are not just asking out of blue of any anatomical questions. There is a reason for our probing or seeking through. Why we are doing these things? Because we want to hammer your brain with this, which are the common thing which comes to us clinically common. Why this is important? Now, this particular humerus is a long bone, is prone to have fractures on it. Now, this particular humerus long bone has a prone fracture regions is there. One prone fracture region is that is a narrow part of this bone which is shaft and the upper part joining here. We call them as neck. That particular neck of the humerus we call them as surgical neck of the humerus. Now the surgical neck of the humerus has an important structure lodging by. We have a nerve and a vascular structure placed on this particular neck region where you have seen this particular black dots is there. So this particular neck region we call them as the neck of the humerus which is lodging a nerve which is known as axillary nerve. Now this particular axillary nerve and along with the nerve which is along with the vascular structure, that means a blood vessel which is known as winging around, we call them a circumflex. So circumflex humeral artery, there is an artery which is present on it. Now what happens if you have fractured this particular part of the bone? Now if you have a bone end torn, it can hit this nerve, so it can hit this particular vascular structure that can damage that. If this particular bone is fractured, that's not only problem that you will be dealing with. So along with the fracture, there is a chances of nerve injury, there is a chances of vascular injury that you have to be mindful of whenever you are dealing with the patients. Getting it? What I am trying to see. So my point is that whenever you are given in a humerus to identify, I will be straight away asking about, tell me about surgical neck and identify this. And you will be saying like, what these things? This you should be asking something like site determinations or something else. But in an examination, we want you to focus or hammer the region which is of importance to us, that separates us from a well-known doctor or a less-known doctor. So we have a fracture, that's a problem with it already, but along with that, the danger or the trouble do not come along. So here we have a fracture that can yield further injuries inside, damaging the nerves. Similar to, we have the spinal groove. The second spot where this particular humerus is prone to have injuries is that shaft fracture. That means we have a trauma, middle portions of the shaft breaks. Commonly breaks at the point where you have the spinal groove. Now if you have a fracture on the spinal groove, we have the structure, same structure lodging in there. So we have two issues to deal with. One is the fracture itself. Second, at the fracture point, the neurovascular structure. At the spiral groove, we have a lodgement of structures. We know that as a nerve which is present on it. We call them as radial nerve. And along with that, there is another artery present in their particular spot. We call that as arteria profunda brachii. That means deep profunda artery. So there is a chances of similarly nerve and vascular injuries. So we have two issues to deal with, and so on, so on. So these are the two things which I am addressing out here. So content on this deltoid tuberosity, spiral groove, and the resultant effect if you have damage on these particular spots which is there. Third thing about this particular region is this one. This particular groove which is lying between these two bones are important to us. We call them as intertubercular sulcus. We have reason for it. I'll be coming into it. This tubercular sulcus is a point of interest for us. Second thing is that these bony projections, we have these projections, we call them as greater tuberosity and the lesser tuberosity. These two projections are very important to us. We always ask about these particular projections and so on, muscle attachment, etc., etc. So we have again reason for asking these particular questions based on this. So this is what we will be focusing on whenever you are studying these particular bones from the front side, back side, etc., etc. So coming from there, landing onto in the shoulder joint. We already have learned about the shoulder joint. We learned about this particular shoulder joint articular parts. We have learned about the shoulder joint, about these movements, muscles involved in this region. Now what we are doing here in this class, we are going to learn the shoulder joint from the posterior aspect or back side, which includes the muscle in the back, which we obscure to us, we do not see them much, and the muscles on the posterior side of the shoulder joint, which is reinforcing the shoulder joint, which we cannot see from the anterior side. And many a times it remains very unclear to us what these muscles are actually doing and why these particular muscles are important to us. So this is what brings us. So muscle in this region can be divided into two halves. One of the muscles is coming from this midline structure, that means the axis, that means from the back side it is coming. So we call them as axial. Two arm, we will call them as axio-appendicular. These arms and these legs, we call them as appendages. So this axio-appendicular muscles, that means they are coming from axis, that means the midline posterior side of the body, and going to the appendages, that means arms. So the back muscles which are ending on the shoulder joint region, back side of these particular appendages, they are known as extrinsic muscles of the shoulder joint. That means they are coming from a far side, dur theke asche. The second group of muscle which is present in here, which is related to the deltoid and the humerus, these two regions. So we call this particular region as a scapulohumeral muscle. They are coming from the scapula and as well as coming from the humerus. So we together call them as scapulohumeral muscles, and they are known as intrinsic muscles of the shoulder joint. What do you mean by this? They are close to the joint, inside of the joint already. They are well appreciated to us whenever you are dealing with it. The far lying muscle or extrinsic muscles, they are far. So our knowledge or our appreciations remains far to us. We often forget about these muscles which we are going to address, right? So let's take one turn at a time. Posterior axial appendicular muscles first, then we move to this particular smaller piece of muscles, and then we understand why it is important to us. Now this is a picture which I pick most often time with this book which we call them as Netter's Atlas. This is like the book which I highly appreciate in learning anatomy, because this is the book which has got nice dissections on it, and looking at the picture itself we can just like understand this anatomy which is very vividly described out here. Now this particular picture, right side of this particular human body and the left side of the human body is not same. So if you see this particular right side, some of the muscles are visible. On the left side there are some other muscles, which is kind of comparative study. So this right side, which is every muscle intact, which you're seeing here, that means the skin is taken off, the fascia is taken off, the fats are taken off, the muscles are exposed, no muscle moved. So this is the most superficial muscle that is present on the back side of our body. So you can see a rhomboid shaped muscle which is coming from this head region, going down to this particular spine of the scapula, then tailing down to this particular back midline. So this muscle which is going down and up, we call them as trap, also known as trapezius. So this particular muscle is also present on this side, but this side it is removed from us. So this is a trapezius muscle, which is a large flat muscle. On the back side it is above, and below the scapula it is present. Now below this we have a flat muscle coming from this particular hip region and ending in grooving in some parts of this arm. So this muscle we call them as latissimus dorsi. In short we call them as lats. So in short we call them as trapezius, as traps, because they are so big names. By the time we finish uttering the name, the patient dies. So that's why we make a small name to it. We call them as traps and lats. So these are the two big muscles that you can see out here. Now these two muscles, especially the traps, are removed in this side. So once these particular traps are removed entirely to this side, you can see deep to it, under to it, we have two small muscles. One is this one, another is this one. This muscle is a small muscle. We call them as rhomboid minor. Below that we have a muscle, we call them as rhomboid major. We call them as rhomboideus minor, rhomboideus major. Just know the names only. And on top of here we have a muscle which is arching or moving up. We call them as levator scapulae. That means it is elevating the scapulae, levator scapulae. These are the three small piece of muscle which is there, which is coming from the axis and ending on the shoulder joints or helping close to the shoulder joint movements. Now if you remove this particular muscle, along with that on the left side you find another muscle which is deltoid muscle. So this deltoid muscle is removed from this side. So this deltoid muscle is an intrinsic muscles of the shoulder joint. It is removed out, and then we can see smaller muscles under to this particular deltoid. This is one above the scapula. We call them as supraspinatus. So spine of the scapula is there. Above the spine we call them as supraspinatus. Below the spine, infraspinatus. Then we have two small muscles likewise, the rhomboid minor and rhomboid major. This is one muscle which is lying on this side. This is small one and this is a big one. So this small one we call them as teres. Above minor and below is major. So these two muscles are two other muscles which are present or hidden by this particular traps and the deltoid. Unless until you remove them, you cannot see them. So this is how they are oriented, superficial to deep. So skin up, this muscle up, then you can see these small muscles. Only the skin up, the straps is there, lats is there, along with this deltoid is visible on this. So this is the orientation of this particular back muscles in the shoulder joint which is present in it. So we take one muscle at a time. This is how the strap is there. We call them as trapezius. So both sides it is going on and making a rhomboid shape which is going up. Now this muscle have some fiber above the spine, some fiber below the spine. So having some fibers above the spine, once this particular muscle contracts, it can elevate the scapula. Similar to this, the lower down fiber, it contracts, it can pull the scapula down. So scapular upward movement and downward movement both can be done with the help of contractions of this particular thing. Now this particular upward and downward movement of the scapula becomes very important on the rotations of the scapula, on rotations of this arm. When you are moving the shoulder joint above 90 degree, then you have to move the scapula up. So then when you have the movement of the shoulder joint happening beyond 90 degree, we have to remove or rotate the scapula up. Then only we can have this arm moving up. So this particular rotation or contractions of the upper fibers which is going on happening here, rotating the scapula in overhead abduction of the arm. So that's why this particular trapezius muscle being a far seated muscle helping the shoulder joint movement. So this is how it is contracting. Along with the middle fibers of this particular muscle is keeping this particular scapula pasted on the rib cage. So the scapula is not moving out, keeping it pasted like this, having assisted on it. So it retracts the scapula. So it is keeping the scapula down. So these are the functions of the scapula. Trapezius, how these things are working. Now above these, what are the content of the muscles and the actions, what I have mentioned out here. The most important muscles is highlighted on the bottom side. So if you ask any important muscle which is important to you, which is exam important, will be this rotation of the scapula in overhead abduction of the arm. These actions of the trapezius is the important action for you. So in examination, if you are given to identify this muscle and ask you the actions of the scapula, if you have to write it number 1, you have to write it this one, rotate the scapula in overhead abduction of the arm. Then elevation scapula, depression scapula, these things. Next muscle, we call them as latissimus dorsi. Big name, in short we call them as lats. Again similar to that, this lats is coming from this particular hip bone, and then from the hip bone this particular muscle taking attachments on the vertebral spines and ending on this particular region of this humerus. Now where it is ending is important to us. It is ending on the floor of bicipital groove, which is also known as intertubercular sulcus. So remember that whenever we are talking about this particular humerus, between this particular greater and lesser tuberosity, we have this cleft, we call them as intertubercular sulcus. That particular sulcus is important. We ask about it because on the floor there is an attachment or insertion of this muscle. What muscle? Lats. Now this particular muscle is very important. This is one of the muscle. Now why it is important? This is coming from back side. You can see that this particular muscle, if your arm is pulled up like this and you are hanging from a tree or something, if you want to pull your body up, so that particular muscle only contracts. So this particular muscle, once it contracts, if you are hanging from some ceiling or somewhere, this raises the lower part of the body towards the arm while you are climbing. This particular muscle is known as climber's muscle. If you are rowing a boat, then also this particular muscle is working, the back side muscle, moving the shoulder joint whenever you are making the movement. So this particular far seated muscle is helping the movement of the shoulder joint from far sides, pulling it up or rowing it. So this is known as rower's muscles or climber's muscle. So these actions of this muscle, the important action. So whenever you have been asked about this particular muscle, the actions of it, you have to write it down that this particular muscle is a climber's muscle or rower's muscle. Elevates the lower part of the body if you are hanging from someone or helping in rowing boats. That's why it is important. Next point is that this particular muscle lying on the back side, once this contracts, can pull the arm back side. So we call them as extension of the arm. At the same time, when it is extending, this particular muscle can do the medial rotation of arm. So if you are extending the arm, this is abduction. And if you are pulling it close, we call them as a double deduction, adduction. So it helps in bringing the arm close to the body, as well as it is helping in extension or putting this arm backwards. So extension, adduction, pulling up, these are the three prime action. Along with that, if you can remember this medial rotation, I will talk about the medial rotation and lateral rotation to make these things a little clear to us, how to decode the actions on medial rotation and lateral rotation. So this trap, the insertion of the traps is very important. So this particular, the lat, insertion of the lat is very important. So we are going to that bicipital groove. So again, I am going to this particular bony class where you have learned. So this groove, we call them as bicipital groove. The floor of it is occupied by the insertion of lats. Now, this is not done. So this particular groove is overlaid by a tendon which is lying on it. So the tendon of biceps brachii runs on the superficial part of it, and the floor is occupied by this particular muscle, which is the lats. So this lat, which is important to us, which you have to really learn well, and the intertubercular sulcus, also known as bicipital groove, it contains the tendon of long head of biceps brachii. So this makes this particular bicipital groove really very high yield for examination. One is the floor. You have to understand the floor. This is floor, and the margin on top of it, running on top of this particular region, is the long head of biceps brachii tendon. So that's why that makes this bicipital groove is very important, because it lodges two important muscles, tendon of biceps brachii, and as well as this particular floor is occupied by this. So get the logic why this is important. So this is how we build in identifying the high yield area in the bones and the clinical anatomy, etc., etc. So moving from here to this particular part, trapezius and latissimus dorsi. So these actions are important and attachments of it. And the lower attachments is coming from the bone in the hip bone, iliac crest. So when you learn about the hip bone, we will talk about the iliac crest, and the muscle attachment of this particular lats again will be coming here. Smaller muscles. Once you take this particular superficial muscles or the rhomboid, you find two muscles. One is this one, rhomboid major, and then we have this particular rhomboid minor. They are kind of muscles which are basically keeping this particular scapula pasted, and as well as they keep this particular shoulder joint reinforced. So, the structural integrity. So, whenever something is moving, there is a jarring movement. So, something is moving. Say for example, we are moving on train, it is shaking, right? So, whenever you are moving any joint or anything, that shakiness will be there. So, we need some kind of tightness around this particular joints to keep this particular joint stable. We call them as buffering of movement. So, these are kind of muscles which is keeping this particular joint very well placed. So, whenever you are making a movement, it is not jarring. So, it is, we can get a very smooth actions on these particular muscles whenever you are getting. Small muscle, we call them as levator scapulae. You get the name, you get the actions, elevate the scapula. So, this particular scapula elevation is done by levator scapulae. So, we will be focusing on the traps and the lats around it in the back, long extensive muscles which is present. Now, coming from the intrinsic muscles, the first one to deal with deltoid. This is the muscle in the shoulder joint. It covers all the rounded contour over here. So, it has anterior fiber, it has middle fiber, it has posterior fiber. So, it has attachment of the spines of the scapula. So, that are posterior fibers. It has attachments on the clavicle, which are anterior fibers. It is covering the middle side over here. So, it has middle fibers. So, it is basically covering the shoulder joint from three different aspects, anteriorly, laterally, and the posteriorly. So, it is basically covering all the shoulder joints. So, having covering on this particular region, it can do any kind of movement in the shoulder joint except one. So, you name any movement of the shoulder joint except one, it cannot do. So it can do any movement except this A double deduction. That means it cannot bring the body close, which is close to the arm. So which is known as A double deduction. It can do flexion of the shoulder joint, it can do extension of the shoulder joint, it can do medial rotation, it can do lateral rotations, and it can do abduction. Except one is A double deduction. So you see that 1, 2, 3, 4, 5. So 5 actions is there out of 6 movements. Shoulder joint have got 6 movements: flexion, extension, medial rotation, lateral rotation, A double deduction, no, abduction, A double deduction. So 6 movements, along with that combinations of everything, circumduction. So everything together, it has a wide range of movement. So it can do any movement except one. What is that? A double deduction. Adduction cannot be done. So that's why this is the muscle. Whenever you given with it, you have to understand this muscle, the actions of the muscle. It has a polyaxial movement, can be controlled because of having 3 different directed nerve muscle fibers: anterior fibers, posterior fibers, lateral fibers. Now, out of these actions, if you have to mention one muscle actions of this particular muscle, what you are going to mention? This is what you have to take about. Abduction from 15 degree to 19 degree. This is the prime moving muscle which is helping out on the shoulder movement. So this particular muscle, these middle fibers contract really strong. So the shoulder joint movement, which can be done from this particular 0 to 15 degree, 15 degree to 90 degree, 90 degree to 180 degree and beyond. So this range of movement of the shoulder joint, out of that 15 to 90 degree is done by the deltoid muscle. So this is the number 1 muscle. I keep it low for deliberate reason because I want to stick it for a longer period of time. It is hanging on the bottom, that doesn't mean it is a last bench student. But I want to emphasize it more because this is the bottom. We spend more time with the bottom students. So this movement is the movement. Then you can utter anything. You name anything except A double deductions about the shoulder joint. This is how this deltoid muscle is working. Then comes teres major, teres minor. Now this particular teres major and teres minor have got 2 different actions. They are counterproductive. Teres major is doing an action, we call them as medial rotation. Teres minor is doing a movement which is known as lateral rotation. Now how this puzzle we can solve about some of the muscle is doing medial rotation and some of the muscle movement is doing lateral rotation. Though they are coming from the same, more or less the same spot and ending on more or less same region. So how we can decode this particular puzzle? About some of them are doing medial rotation, some of them are doing lateral rotation of a joint. So how we can decode this problem? কি করে সলভ করতে পারবো যে কিছু মাসল মিডিয়ালি রোটেট করে দিচ্ছে, একই জায়গা থেকে আসছে, মোরলেস একই জায়গায় গিয়ে শেষ হচ্ছে, আবার কিছু মাসল উল্টো কাজটা করছে। মিডিয়াল রোটেশন ক্লোজ টু মিডিয়াল লাইন ইনসারশন। আচ্ছা, বেশ বেশ, থ্যাংক ইউ। আর কি করে ইজিলি আইডেন্টিফাই করতে পারবো বলো? অ্যান্টিরিয়র সারফেস, অ্যান্টিরিয়র সারফেস হলে মিডিয়াল রোটেশন। আর এবার কার অ্যান্টিরিয়র সারফেস একটু ক্ল্যারিফাই করো। ইউ আর দেয়ার লাইক 90% দেয়ার। কার অ্যান্টিরিয়র? হ্যাঁ, হিউমেরাস। ওকে, আর একটু ক্ল্যারিফাই করতে পারবে? পারবে তুমি? ইউ ক্যান ডু ইট। কেউ হেল্প করো। ও গেছে ওই জায়গায়, অ্যান্টিরিয়র সারফেস বলছে, হিউমেরাস বলছে, আর একটু রিফাইন করলেই ব্যাপারটা পেয়ে যাবো আমরা। মিডিয়াল মানে যাই, তুমি অ্যান্টিরিয়র বলেছো, ঠিক আছে, একদম ঠিকই বলেছো, কিন্তু টার্গেটটা একটু অন্য হবে, জাস্ট একটু অন্য। So the easy rule is that whenever we sit down, please. Whenever we are addressing a movement, what we are focusing here is joint. So any muscle, whether inserting on this particular regions, whether it is anterior to the joint if it is ending, or if it is posterior to the joint if it is ending, that basically decides on the actions of the muscle. So if a muscle is ending on anterior to the joint, and if a muscle is ending on posterior to the joint, that decides on the actions on the rotations. So if it is ending on anterior to the joint, it will be a medial rotator. So if they are ending on posterior to the joint, it will end up in lateral rotations of the joint. So this is a simple rule that you have to appreciate, whether these particular muscles are ending to the anterior aspects of the joint or posterior aspect of the joint. We have same picture over here. So you see the insertion of these or attachments of these particular muscles on the humerus. Focus on the insertion point of the teres major and teres minor. So you see that teres major is reaching across, ending on anterior aspects of this particular joint, সামনের দিকে চলে যাচ্ছে, and teres minor is ending on the back side of the shoulder joint. কি করে বুঝবো? Focus on the scapula and the spines of the scapula. The spine of the scapula is the posterior side. তুমি দেখো যে muscle attachments কোথায় আছে? Back side এ রয়েছে, আর এখানে muscle attachment কোথায় আছে? Grooved in, সামনের দিকে চলে যাচ্ছে। তো সেই aspects of the insertion point আমরা যদি দেখি, that will help us to identify. So same again over here, you see that this is teres minor. কোথায় শেষ হচ্ছে? On the back side. It is ending on the back side. Where is teres major is going? This particular teres major is going here in between this groove and ending in the front side. এটা long course চলে যাচ্ছে। Similar to it, তুমি দেখো এই মাসলটা, এটা কি মাসল? ল্যাট। এই ল্যাট মাসলটা কোথায় শেষ হচ্ছে? দেখো এইখান দিয়ে গিয়ে সামনে চলে যাচ্ছে। So that's why this particular সামনে চলে গেলে যখন কন্ট্রাক্ট করছি, it is rotating this joint medially. So if this particular muscle is ending anterior or posterior aspects of this thing, we can denote the actions of it. Posterior to it, it will be lateral rotator. Anterior to it, it will be medial rotator. Now if any muscle is doing this medial rotation, we get a free extra assisted movement. So if it is doing medial rotation, it can also do adduction of the joint. So this is a simple rule you can add on about the muscles movement of the smaller thing, anterior to it or posterior to it. If it is a medial rotator, either it will be directly assisting or doing this adduction or helping this A double deduction. Clear? So this is how we solve the puzzle, how the muscles is ending on it and how those muscles are working on it. This is ending on the posterior side. Once it contracts, it will be laterally rotating. This is ending on the front side, contracts, it will be medial rotating. It will be pulling inside. So this is how this A double deduction is there along with this medial rotation. So কেউ medial rotation করলেই তার সাথে free movement পাচ্ছি আমরা একটা A double deduction, মানে adductionটাও আমরা free movement হিসেবে accumulate করতে পারছি। Now other two muscles, supraspinatus, infraspinatus, which is lying below it. So this muscle above the spine, supraspinatus. This is a muscle which is ending on top of this joint. Once this muscle contracts, it initiates the shoulder joint movement. So initiation of the shoulder joint movement means 0 to 15 degree shoulder joint movement is done by the supraspinatus. That means যদি আমরা গাড়ি স্টার্ট করি, first gear of the car is done by the supraspinatus. So movement initiation. So এই মাসলটা কোনো ড্যামেজ হয়ে গেলে আমাদের শোল্ডার জয়েন্ট মুভমেন্টই শুরু করতে পারবো না, রাইট? সো supraspinatus is doing the initiation abduction or initiation abduction movement 0 to 15 degree over there, which is below occupied by infraspinatus. Infraspinatusটা কোথায় শেষ হচ্ছে? Anterior to the joint or posterior to the joint? Posterior to the joint. Posterior to the joint হলে কি মুভমেন্ট করবে? করছে lateral rotation. Similar to it, right? Coming to it, likewise, subscapularis. Subscapularis কোনটা? এই দেখো anterior view, এটা হচ্ছে posterior view. Anterior view তো subscapularis কোথায় করছে? জয়েন্টের রেসপেক্টে, anteriorly না posteriorly? Anteriorly. তাহলে কি মুভমেন্ট করবে? medial rotation. Medial rotation যদি করে free rotation কি পাবো, free movement কি পাবো, adductions. মিলছে অঙ্কটা? So makes these things clear, right? So this is how we are going to study whenever you are making a movements of this. Now comes to clinical part. This is what you have learned. So all these muscles which you have mentioned, supraspinatus, infraspinatus, teres minor and subscapularis, they are together making a common tendinous insertion point. এরা কি করছে, সমস্ত মাসেল গুলো এই দেখো শোল্ডার জয়েন্টের around, they are making a nexus of the cartilage, nexus of this tendinous conglomeration. So they are inserting like this, SITS, subscapularis, smaller ইয়েতে tuberosity তে ইনসার্ট করছে, আর লেসার গ্রেটার tuberosity তে SITS, এই উপর থেকে নিচে এরকম ভাবে ইনসার্ট করে with this particular pictures like this. So likewise এরা এরকম ভাবে ইনসার্ট করছে। তো এই all the muscles which are known as seats, that means these are the muscles which is known as supraspinatus, infraspinatus, teres minor and subscapularis. They are stabilizing this particular shoulder joint or these stabilizing factors of the shoulder joint. How? They are making a musculotendinous rotator cuff. That means এটা sleeve করছে shoulder joint টাকে পুরোপুরি. They are ensleeving the shoulder joint above, anteriorly, posteriorly and as well as superiorly, and making a sleeve around the shoulder joint, and this sleeve we call them as rotator cuff. They are made by the tendons of these muscles. কোন টেন্ডন? দেখো আবার আমরা এই পিকচারে ফিরে গেলাম, কিরকম হচ্ছে, এই দেখো এই মাসেল গুলো গিয়ে এই শোল্ডার জয়েন্টে গিয়ে শেষ হচ্ছে, এইখানে ক্যাপসুলের সাথে এডহারেন্ট করে যাচ্ছে। We are making a encapsulated enhancement point. So this is a rotator cuff, or the protections of the shoulder joint is contributed by this rotator cuff. And if you have tear or injuries to the rotator cuff, we have problem on the shoulder joint movement, pain on the shoulder regions will be there, pain on movement will be aggravated, likewise will be there. So out of this particular region of the shoulder joint or rotator cuff, the most weakest point of this particular rotator cuff is the inferior side. কেন inferior side বলছি, এগেইন আমরা এই ছবিতে চলে যাচ্ছি। দেখো inferior side, দেখো এই জায়গাটাতে empty আছে, we do not have any muscles which is continuing on the inferior side, neither it is tendon which is encroaching. So that's why the inferior aspects of the shoulder joint is weakest. তার জন্য shoulder joint inferiorly খুব তাড়াতাড়ি drop out হয়ে যায়, মানে dislocation হয়ে যায়। So that's why this is inferiorly dislocating. So আমরা লজিকটা জানলে we can just like explain it. During examination আমরা এই কোশ্চেনটা দিই, the shoulder joint dislocation is commonest to the inferior side. Explain why. কেন explain করব? With the seats, rotator cuff এর lower part inferiorly, reinforcement নেই, lower part basically empty. তো তুমি যদি বন্ধুকে বলো উঠে দাঁড়া, আমি তোর হাতটা ধরে হ্যাচ করে টানছি, ব্যাস হয়ে গেল, shoulder joint dislocated হয়ে গেল, এবার যা তুই ঘুরে বেড়া। So that's why this inferior part of the shoulder joint is prone to have dislocation. We call them as inferior dislocation of the shoulder joint. So this particular shoulder joint dislocation is common to which side we understood, and what are the normal reinforcement of the shoulder joint, which is known as the rotator cuff, we understand. And who makes the shoulder joint? We know that. Now out of these four muscles, এই চারটে মাসেলের মধ্যে কোন মাসেলটা সবথেকে বেশি prone to have injuries, that you have to know additional to it. এই প্রথম মাসেলটা কোন মাসেল? supraspinatus. এই supraspinatusটা weakest of all these muscles, and it is prone to have injuries. So this particular supraspinatus muscle injury or supraspinatus injury is quite common. We call them as rotator cuff injury, which is more common or very common in cricket players, bowler যারা বল করে, যারা বেসবল খেলে, থ্রো করে, throwers, they have a very weak of the shoulder joint muscles, are very prone to have injuries to the rotator cuff. যারা ব্যাডমিন্টন খেলে, যারা টেনিস খেলে, ওভারহেড স্ম্যাশ করতে হয়, they have to just like do it, go back and smash. So এই shoulder joint এর মুভমেন্টে, during this movement, rotator cuff frictions and injuries হয়। তো কোন মাসেলটা বেশি ইনজুরি হয় সেটা হচ্ছে the supraspinatus। কেন? এই দেখো এখানে ক্ল্যাভিকেলটা আছে আর এখানে অ্যাক্রোমিয়ান আছে, সো এইখানে দুটো বোনস কাছাকাছি আছে। আমরা যদি খুব রিপিটেডলি মারি এরকম করে স্ম্যাশ বা ওভারহেড বল ছুরি, এই বোনের আন্ডারে এটা ফ্রিকশন হয়ে যায়। ফ্রিকশন হয়ে গেলে কি, ঘষা হয়ে গেলে নষ্ট হয়ে যায়। So that's why this particular muscle, supraspinatus, having its position between this clavicle and acromion process, is prone to have injuries. So supraspinatus injury is inevitable in case of the sports person like baseball throwers, cricket ball throwers, smashers like the tennis players, the badminton racket players, etc., etc. So they have very chances of very commonly gets this rotator cuff injury. So supraspinatus tear is very common. কি হয়, ব্যথা হবে, মুভমেন্ট করতে গেলে কষ্ট হবে, এই will be complaints of it. So this is why again supraspinatus কি অ্যাকশন করে শোল্ডার জয়েন্টে, abduction. কোন abductionটা করে, 0 to 15 ডিগ্রি। তার মানে পেশেন্ট এসে কি বলবে যে আমি হাতটা তুলতেই পাচ্ছি না, হাতটা সরাতেই পাচ্ছি না, প্রথম দিকটা, তারপরে যদি কেউ তুলে দেয় তারপরে এটা তুলে নিচ্ছি কি করে। সো প্রথম 15 ডিগ্রি সুপ্রাস্পাইনাটাস অনলি, আর কোনো অ্যাসিস্টেড মাসল নেই। সো সুপ্রাস্পাইনাটাস তুলে দেওয়ার পরে তারপরে কি আছে, ডেলটয়েড, ডেলটয়েডটাকে তুলে দিল, বাকিটা কি হলো, ল্যাটস, ট্র্যাপস হেল্প করে দিল। সো the initiation of movement is defective in a person who have the shoulder joint injury, rotator cuff, notably supraspinatus tear. So explain why a patient who is coming to your clinic, who is a professional racket player, coming to you with the complaints of pain on the shoulder, which is aggravated when they try to intend to abduct the arm, armটাকে মুভ করতে গেলে, or raise the arm, or unable to move the arm, তোমাকে এক্সপ্লেইন ওয়াই করতে হবে। তার মানে কি বলতে চাইছে, শোল্ডার জয়েন্ট ইনজুরি, শোল্ডার জয়েন্ট ইনজুরি মোস্ট কমনলি কি এফেক্ট করছে, রোটেটর কাফ। রোটেটর কাফ কে কে আছে, এই চারটে জিনিস আছে, চারটে জিনিসের মধ্যে কোনটা বেশি কমন ইনজুরি, সুপ্রাস্পাইনাটাস। সুপ্রাস্পাইনাটাস ইনজুরি হলে কি হবে, আমার এবিডাকশন মুভমেন্ট এরার হবে, পুরো এবিডাকশনটা হবে নাকি পার্টলি হবে, না শুরু অফ এবিডাকশন হবে। তার মানে আর্মটা সরাতে গেলে প্রথম পার্ট অফ দ্য 15 ডিগ্রি, এটা 0 ডিগ্রি থেকে 15 ডিগ্রি যেই নিচ্ছে বলছে ব্যথা, এটা পাচ্ছেই না, তার মানে টেয়ার হয়ে গেছে। পার্শিয়াল টেয়ার যদি একটু পারে, যদি পুরো কমপ্লিট টেয়ার হয় পারবেই না, তোমাকে হাত দিয়ে সরিয়ে দিলে, তুমি এখানে সরিয়ে দিলে তারপরে বাকিটা সে করে ফেলছে। সো দিস উইল বি দ্য ট্রিগার পয়েন্ট হাউ ইউ আর ডিকোডিং ইট। আদার দ্যান দিস সুপ্রাস্পাইনাটাস সাবস্ক্যাপুলারিসেরও ইনজুরি হয় ভেরি কমনলি, বাট ঠিক আছে আমরা এইটুকুই জানলাম, বাকিটা তোমাদের ক্লিনিক্যাল স্যাররা পড়বে, সব আমি পড়িয়ে দিলে আর ওরা কি করতে পায়। সো দিস ইজ হাউ দে আর কামিং আপ। এই তুলতেই পাচ্ছি না, হাতটা এইটুকু তুলতেই পাচ্ছি না, এই তুলে দিলে তারপরে তুলে নিচ্ছি, ঠিক আছে। তো এই ধরনের ইনজুরিজ আর কোয়াইট কমন। কি করে রিপেয়ার করবে, ও অপারেশন করতে হবে, কিছু করার নেই। সো ইউ হ্যাভ টু জাস্ট লাইক ডিব্রাইভ দিস, কাট দিস থিংস, দ্য ক্যাপসুল আউট, কেটে এই জায়গাটা নতুন করে স্টিচ দিতে হবে, তারপর রিহ্যাবস পাঠাতে হবে 6 উইকস 8 উইকস, এটা হিল করবে, তারপরে এক্সারসাইজ ফিজিওথেরাপি করেই যেতে হবে, করে 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 রিকভার করবে। ইট ইজ ভেরি ভেরি চ্যালেঞ্জিং, মানুষের কেরিয়ার শেষ হয়ে যায়। যারা স্পোর্টস পারসন, এই একটা ইনজুরি ইজ গোয়িং টু রুইন দ্য কেরিয়ার, লাইফটাই বদলে দেয় এদের। সো দে ইদার হ্যাভ টু চেঞ্জ দিস কোর্স। লাইফের অনেক ক্রিকেট প্লেয়ার আছে যাদের কিনা কেরিয়ারটা বিফোর ইট বিগিনস ইট এন্ডস। তো কি করতে হবে, প্রিভেনশন ইজ দ্য বেস্ট থিং। আগে প্রিপারেশন করতে হবে, মানে এক্সারসাইজ করতে হবে, এই মাসেলগুলোকে আগে স্ট্রং করতে হবে, তারপরে খেলতে যেতে হবে। যেমন শুধু খেলতে চলে গেলাম হবে না, মাসেল উইক থাকলে ইনজুরি হবেই। So this is how we are dealing with it. Before we end, so this is about shoulder joint, the clinical points of the shoulder joint, and this is about the space which is lying on the back side. So this is what we are going to talk about, and later on আমরা এই জিনিসটা আরো পরে অ্যাপ্রিশিয়েট করব। দেখ দুটো জিনিস আছে, there are some spaces lying in this region of the back shoulder region. দুটো স্পেস আছে, আমরা বলি ট্রায়াঙ্গুলার অ্যান্ড কোয়াড্রাঙ্গুলার স্পেস, আর আরেকটা বলি ট্রায়াঙ্গেল অফ অসকালটেশন। এই দুটোই ক্লিনিক্যাল ইম্পর্টেন্ট টু আস, কোশ্চেন আসে এবং ক্লিনিক্যালি ইম্পর্টেন্ট। সো এই জিনিসটা আগে শুরু করা যাক, এটাকে বলি আমরা ট্রায়াঙ্গুলার অ্যান্ড কোয়াড্রাঙ্গুলার স্পেস। কিছু ইমাজিনারি স্পেস রয়েছে, সেই স্পেসটা কি, বাউন্ডেড বাই সাম মাসকুলার রিজনস। সো উই হ্যাভ সিন দিস পার্টিকুলার রিজন। এটা দেখছো যে ব্যাক সাইড অফ দ্য শোল্ডার জয়েন্ট, এটা হচ্ছে স্পাইনস, এটা হচ্ছে হিউমেরাস, এটা ব্যাক সাইড অফ দ্য শোল্ডার জয়েন্ট, এটা হচ্ছে সুপ্রাস্পাইনাটাস, ইনফ্রাস্পাইনাটাস, টিরিস মাইনর, টিরিস মেজর। এটা দেখো হিউমেরাস, হিউমেরাসের উপর ডেলটয়েড, এটা কাটা আছে, partly opened here, তার জন্য হিউমেরাসের আপার পার্টটা দেখা যাচ্ছে, এটা নেক রিজন অফ দ্য হিউমেরাস। তলার দিকে যে মাসেলটা আসছে এটাকে বলে ট্রাপিজিয়াস, ব্যাক সাইডে এই মাসেলটা আছে ট্রাপিজিয়াস। ট্রাপিজিয়াসের 3 হেডস আছে, তার মিডিয়াল হেড, ল্যাটারাল হেড আর লং হেড। এই যে হেডটা চলে যাচ্ছে লম্বা মতো, এটাকে আমরা বলি লং হেড অফ ট্রাপিজিয়াস, যেটা মিডিয়ালি থাকে, মানে ক্লোজ টু দ্য বডি। সো মিডিয়াল হেড অফ দ্য ট্রাপিজিয়াস এখানে দেখতে পাচ্ছ, আর এইখানে যেটা দেখতে পাচ্ছ সেটা হচ্ছে ল্যাটারাল হেড অফ দ্য ট্রাপিজিয়াস, আর ডিপে মিডিয়াল হেডটা থাকে। সো দিস ল্যাটারাল হেড, এটা দিয়ে স্ক্যালপেল দিয়ে কাটছে, দেখো কেটে এই স্পেসটা বার করেছে। সো এখানে দেখো তিনটে স্পেস উই ক্যান অ্যাপ্রিশিয়েট, দেয়ার আর 3 স্পেসেস আউট হিয়ার। One of them is square shaped space, we call them as quadrangular space. সেই স্পেসে কিছু নিউরোভাস্কুলার স্ট্রাকচার আছে যেগুলো আমরা সবাই জানি। আর দুটো স্পেস আছে, there are triangular spaces. Two of them are triangular spaces. One of them is lying above, we call them as upper triangular space. One of them is lying below, we call them as lower triangular space. এই আউট অফ দিস দুটো ট্রায়াঙ্গুলার স্পেসের মধ্যে লোয়ার ট্রায়াঙ্গুলার স্পেসটা ইম্পর্টেন্ট। কেন ইম্পর্টেন্ট তুমি বুঝতে পারবে এবং তোমরা সেটা জানো। So let's talk about the triangular space and the boundaries of it. So you see that we find a square, let's talk about this quadrangular space first. We see a square shaped space over here. এটা একটা চৌকো জায়গা, এরকম করে চারটে বাউন্ডারি ইমাজিনারি জায়গা আছে। So between the muscles and the bones, so we have a muscle above, which is lying below, above is teres minor. We have a muscle which is making a floor out here, which is known as teres major. So above minor, niche major. This is the medial side, this is the lateral side. Medial side e dekho ei long muscle ache, etake bola hoye triceps, long head of the triceps. Edike dekho humerus আর medial head, lateral head of the triceps রয়েছে। So in between the lateral head of the triceps and the humerus and this long head of the triceps and above by teres minor and major, we have a square shaped space. This space we call them as quadrangular space. এই বাউন্ডারিটা লিখে রাখতে হবে, জানতে হবে আমাদের। Above minor, নিচে major, medial side এ triceps long head, lateral side এ আমার long head of the lateral head of the triceps. এখানে কিছু স্ট্রাকচার যাচ্ছে। এই জায়গাটা কোন জায়গা? Basically this space is replicating here. So this space is representing the region of this humerus. We call them as neck of the humerus. Neck of the humerus এ কি স্ট্রাকচার আছে যেটা ইম্পর্টেন্ট, ফ্র্যাকচার হলে লেগে যেতে পারে? axillary nerve, আর একটা আর্টারি আছে, সেটা সার্কামফ্লেক্স। সার্কামফ্লেক্স মানে জড়িয়ে ধরেছে। So circumflexing branch of circumflex humerus, so circumflex humeral artery. এই দেখো লাল আর একটা হলুদ, সেই হলুদটা কি? নার্ভ। কি নার্ভ? axillary nerve। আর লালটা কি? আর্টারি। আর্টারি মানে ব্লাড ভেসেলস আছে। circumflex humeral artery. So this region, the quadrangular space is occupied with the neck of the humeral structure which is lodging on. বোঝা গেল কেন ইম্পর্টেন্ট, কেন বলছি? যখনই আমরা এই হিউমেরাসটা ধরাবো, ধরিয়ে বলবো নেক অফ দ্য হিউমেরাস আইডেন্টিফাই করো, নেক্সট কোশ্চেন আমরা বলবো যে এখানে কি স্ট্রাকচার আছে, ফ্র্যাকচার হলে কি ড্যামেজ হয়ে যেতে পারে, এন্ড ইন এ ক্যাডাভার বডি এন্ড লিভিং বডি এটা কোন জায়গার বা কোন স্পেসের সাথে রিলেট করছে। বোঝা গেল? সেই জন্য এই স্পেসটা আর কন্টেন্টটা ইম্পর্টেন্ট। বোঝা গেল? নেক্সট ইজ দ্য ট্রায়াঙ্গুলার স্পেস। এখানে দেখো একটা ট্রায়াঙ্গুলার স্পেস আছে ছোট্ট, আর এইখানে দেখো একটা ট্রায়াঙ্গুলার স্পেস আছে স্মল অ্যামাউন্ট। These two smaller spaces, a triangular space 1, triangular space 2. কি বলবো? Upper triangular space UTS and lower triangular space LTS. So focus on the lower triangular space. Lower triangular space এ কি বাউন্ডারি আছে? এই দেখো teres minor উপরে, teres major নিচে। So teres major এটা কি? triceps। কোন triceps? long head। এটা কোন triceps? medial head। So medial head of the triceps, lateral head of long head of the triceps and teres major, তার মাঝে এই ছোট্ট স্পেসটা রয়েছে যেখান দিয়ে আবার একটা হলুদ আর একটা লাল স্ট্রাকচার চলে আসছে। এই স্পেসটা রিপ্রেজেন্ট করছে কোন জায়গায়? ইন এ বডি ইজ দ্য স্পাইরাল গ্রুভ অফ দ্য হিউমারাস। স্পাইরাল গ্রুভে কি থাকে? রেডিয়াল নার্ভ থাকে, আর কি থাকে? একটা আর্টারি থাকে, আর্টারিয়া প্রোফান্ডাম ব্র্যাকাই, ডিপ প্রোফান্ডা আর্টারি। তার মানে কি এই জায়গায় ফ্র্যাকচার হলে কি হবে? এইগুলো ড্যামেজ হয়ে যাবে। ইন এ লিভিং কন্ডিশন তখন তো তোমার বোনসটা খুলে দেখবে না, যখন পেশেন্ট আসবে কি বলবে? এই জায়গাতে হয়েছে। তোমায় জানতে হবে এই জায়গায় যখনই তুমি অপারেশন করতে যাবে তখন তাকে জানতে হবে কি এই স্ট্রাকচারগুলো রয়েছে, এগুলো ড্যামেজ হয়ে যেতে পারে। সো দিস লোয়ার ট্রায়াঙ্গুলার স্পেস ইজ বেসিক্যালি রিপ্রেজেন্টিং দ্য স্পাইরাল গ্রুভ অফ দ্য হিউমারাস and content of it is coming out of it. বোঝা গেল কেন ইম্পর্টেন্ট? So these are important structures. Over here is upper triangular space, less important, I skip that. মাথা হেভি হয়ে যাচ্ছে, এমনিও দরকার নেই। এই বাউন্ডারিজ অফ দিস, এই পিকচারটা মনে রাখবে, তারপরে এই জিনিসগুলো একটু আস্তে আস্তে রিহার্স করবে, একবারে মনে থাকবে না। উইল বি রিহার্সিং ইট এগেইন এন্ড এগেইন টু আন্ডারস্ট্যান্ড ট্রায়াঙ্গুলার স্পেসের বাউন্ডারি অ্যান্ড কন্টেন্ট অ্যান্ড লোয়ার ট্রায়াঙ্গুলার স্পেসের বাউন্ডারি অ্যান্ড কন্টেন্ট বেশি ইম্পর্টেন্ট, সেটা আমাদের বেশি জানতে হবে। ঠিক আছে? লাস্ট বাট নট দ্য লিস্ট, এটাই আমার শেষ কোশ্চেন। গত বছরে বোধহয় কোশ্চেন এসেছিল এটা, triangle of auscultation and the boundaries. Now there is a reason of understanding this. Now what do you mean by the triangle of auscultation? গল্পটা হচ্ছে we started with this with a story. কিরকম হলো? So there is a murder in US, in UK, in a suburb region, where there is a person killed, but no structures was damaged. At a back stab করা হয়েছিল. There was a stabbing on the back, and within that particular stabbing on the back was done, and there was not a single muscle, not a bone was harmed to kill this person. How it happened? The person choked on having a collapsed lung. At lungs-টাকে collapse করে মারা গেছে. So they investigated. It's a long time, 16th century গল্প. তো কি করে এরকম সম্ভব হলো? Without damaging anything, কি করে সম্ভব হলো? So here comes the theory, আর তারপরে সেই জিনিসটা দেখা গেল যে আমাদের বডিতে এমন একটা জায়গা রয়েছে যে জায়গায় we can approach to the lung without touching any muscle fibers or nerve structure or bones or anything. We call them as open area of the lung. যেটা যদি আমরা penetrate করতে পারি আমাদের কোনো বাধা থাকবে না. We just directly can hit the lung and rupture or kill the person. So this particular region, ডাক্তার হয়তো বলতে পারবি না যে ওখানে মারলে আপনি মরে যাবে, তো আমরা অন্যভাবে নাম দিলাম. কিভাবে নাম দিয়েছেন? বলছে ট্রায়াঙ্গেল অফ অসকালটেশন. মানে এখানে যদি আমরা বেল অফ দ্য স্টেথোস্কোপ আমরা রাখতে পারি তাহলে আমরা খুব ভালো ব্রেথ সাউন্ড শুনতে পারবো. এবং সেভাবেই হয়ে গেল, সেভাবেই অ্যানাটমিটা পড়ানো হলো. তা না হলে আমাকে পড়াতে হতো কি কিভাবে পেশেন্টকে মারতে হয়, কিভাবে মানুষকে মারতে হয়. দ্যাট উইল বি এ ক্রাইম. So we cannot do that. So we cover these things with a nice presentation about triangle of auscultation. So we place a bale of the stethoscope on the back of our body and can hear the lung without any obstacles. So key say boundary there, যেটা বলে triangle of auscultations. So back side আমরা muscle দেখেছি, right? So we move back to the same age old picture of these nature sadness. প্রথমে যে পিকচারটা দিয়ে শুরু করেছিলাম সেই পিকচারে চলে যাচ্ছি. So we have this particular back side muscles there. We have a muscle, we call them as lats. We have lats. It's a lat, right? So it has an inferior boundary of lat. This is a lateral boundary of this muscle. Key muscle? Trapezius. So traps and lats meets the point. এইখানে. আর এই মাসেলটাকে তুলে দিলে এখানে একটা বোনস রয়েছে. কি বোনস? Scapula. So a scapular medial border, inferior border of this lats and this medial border of this trapezius holds a triangular space over here on the midline or close to midline. This is what we call them as triangle of auscultation. এখানে আর কোনো muscle, কোনো bones, কোনো কিছু inference নেই. We can directly hear the lung out on this particular region. So this is known as triangle of auscultation, which is a point of concern to us. We can really hear the lung sound or breath sounds placing the bell of the stethoscope at triangle of auscultations. So medial border is formed by this trapezius. Lateral border is this lateral border of the scapula, is the scapular margin, and inferior border by the lats. So this black shadow, this region is a good place to hear the posterior base of the lung, or else we can hear the lungs without any obstructions. So a boundary টা কে করছে আর significance of it. So triangle of auscultation is a point where the boundary is important, and understanding why this particular thing is called triangle of auscultation, because এই জায়গায় আমাদের কোনো obstacles নেই, কোনো muscle নেই, কোনো bones নেই. আমরা lower part of the lobe, lungs এর লোবটাকে আমরা পরিষ্কার শুনতে পারি. কেমন? So go back to your home, find a stethoscope and try to identify with the sketch marking the triangle of auscultation.